We're going to go ahead and get started. You all know me, but I'm Vicki Robinson, and I work here at PHI with Dr. Robertson and coordinate the valve clinic. And today we're going to talk about TAVR. And TAVR is, I just labeled it TAVR 101, everything that you always wanted to know, but were afraid to ask. So you have a lot of handouts. This is every piece of information that you should ever need if you have to order anything for TAVR, if you would fill in for the valve clinic, if you were discharging a patient, and we'll go over everything. And I'm going to try and keep this to about a half an hour. So the usual flow for a patient through the valve clinic is once that referral is placed, ambulatory referral to valve clinic. Scheduling is great about giving you an appointment, an arrival time, and for all new patients, that arrival time is 11 a.m. The reason for that is they attend an education class. And in your folder here, I'm not going to go through all the slides. This is the information that all new patients receive. They have about an hour's worth of education, anatomy and physiology of the heart and how it works, where the aortic valve is, what it does, some of the signs and symptoms that aortic stenosis causes, their treatment options, testing that they may be recommended for in the clinic. So that all happens during that education class. Normally that's from about 11 to 12. At 12 o'clock then, we give them a lunch voucher. We give 2 lunch vouchers per family so that they can then go to lunch. They can kind of digest all the information that they've just heard. They may come up with some questions among themselves that they can then, when they see the doctors, ask those questions and be a little more educated. That's really cut down on the amount of time that the physicians are spending in the room with the patients. Before, they were spending an average of about 20 minutes going over all the information in the education class. So that left very little time for treatment recommendations, going over risk and benefits, and so forth. So that's really made a difference with the patients too. After their visit, or after they go to lunch, they'll come back to the cardiology office and check in just like a normal appointment. They'll check in, we get them back for their visit. During that visit, we do the usual weight, vital signs. They do a walk test. Tammy Flogger will walk them a short distance, and that's to assess how the aortic stenosis is affecting their lifestyle. We also have them complete a KCCQ, which is a Kansas City questionnaire that assesses how it's affecting their lifestyle and what they're not able to do that they used to be able to. More activities that go on during a visit. Usually, when they're there for a visit, an interventional cardiologist, which is either Dr. White or Dr. Robertson, along with one of the cardiovascular surgeons, Dr. Greenlee or Dr. Gray, will go into the patient room at the same time. They have already reviewed the patient history, which we'll talk about in a little bit. So they already kind of have a plan formulated for this patient. They talk about the recommendations, the testing that the patient needs, and then everything is scheduled from there. So we're down here. So we schedule all that testing. The patient leaves that visit with their appointments, their dates and times, all their patient instructions, and a second clinic visit appointment. So there's a lot of scheduling that goes on. And I just wanted to put in in that referral, back to that referral, there are 2 hard stops in there that are asked. And that's one, have they had an echo within the last 6 months? And have they had a nuclear stress test within the last year? I know there have been some physicians that are pretty hesitant about ordering a nuclear stress test. The reason that we put that in there is if they fail that nuclear stress test or it shows any signs of ischemia, then the patient will need to have a heart catheterization to assess the coronary anatomy for any blockage. Without that, that delays treatment a little bit longer because we have to get a nuclear stress test to assess for that ischemia and then move on from there. Yes?
If they've had a heart cath, we don't have to do another test.
Correct, correct. If they've had a recent heart catheterization, then you don't have to do the myoview. But they have to have one or the other or both.
What's considered recent?
Within the
year?
Within the last year.
Okay.
And the myoview can be with, it doesn't have to be with the physician, it can be with,
No.
Okay.
No, it can just be.
because they have aortic stenosis, so they're higher risk for even a treadmill. so
Correct,
that's why, yeah.
correct. And.
Can it be a Lexa scan?
For imaging, if their mean gradient per echo is greater than 30, it has to be a Lexi scan.
Yeah, okay. And most of them, by definition, are gonna be greater than 30, I would think.
Most of them are,
Yeah.
yes. So after all this testing is completed, we discuss patients at case review, which is on TAVR Mondays, which is every other Monday. Usual TAVR Monday starts with a pre-case conference at 6:30. They do 2 TAVRs. Then we do case review at noon. This is where we review all this testing. We talk about any new patients that have been referred, look at their medical history, they kind of formulate their plans, and then also decide what kind of valve might be used. We have 2 valves now that can be used. One is an Edwards valve, the Sapien valve, it looks like the little crown. I have a model sitting on my desk. And the Medtronic core valve. Depending on the patient's health history, if their past health history will not allow, or their cardiac health will not allow for a little short time of rapid pacing, typically then we recommend the core valve because there's not as much rapid pacing that occurs to get that valve in place. Then behind the scenes, in between times, I have those images uploaded to either Core Valve Connect or Valve Point. That allows our representatives to pull those images. They do specific measurements and then send us a report with their recommendations as far as what the best route of access is, the size valve they're recommending, and then we correlate that with what the physicians are thinking and then finalize the plan. So during the patient's second clinic visit, they again meet with an interventional cardiologist and a surgeon, and we attempt to schedule them back so that they see the opposite surgeon that they saw before. Because according to Medicare guidelines, for Medicare to cover a TAVR procedure, they have to have 2 cardiovascular surgery opinions. So that can be kind of tricky sometimes, but that's what we have to do to get Medicare to cover. So their testing is reviewed with the patients and recommendations are discussed and a surgery date's given. So at that second clinic visit, when we give them a surgery date, I also put in all the PAT orders, the pre-op orders, and if the patient lives a distance or the TAVR is going to be very soon, I'll send them to PAT the same day. If not, PAT will contact the patient to schedule them in. And the PAT has to be done. We have patients that come from Michigan, from quite a ways into Ohio. down around Marion and Muncie, and the question always is, well, can they do the PAT, the blood work, closer to home? And the answer is no, because we also type in screen for 2 units of blood. And for that type in screen to be accurate and for the hospital to accept it, it has to be done here at our hospital. So these are the labs that have to be ordered. Pre-op wise, some are hemoglobin A1C only if the patient's diabetic, and a PTINR if the patient's on warfarin. Instructions, and you have these instructions in front of you. TAVR Instruct goes through the pre-op instructions for the patient. It's on this single piece of paper. So you just F2 through this, schedule the time with procedure scheduling. Normal arrival times for TAVR patients are 5 a.m. for the first case, 7 a.m. for the second case, 10 a.m. for the third case, and noon for the fourth case if we're doing a fourth case. So there's a little bit of leeway there, but that's what myself and Candy and Deidre have kind of come up with that works the best. The patient is not there an extensive amount of time, but they still have plenty of time to get them ready. They'll go back to the cath lab about an hour prior to their actual procedure time. We still use general anesthesia for all these patients, so anesthesiologist will put them to sleep, start all their lines. Most of the time they'll get an IJ, so that's put in after the patient's asleep. And then recommendations for medication holds are down here. Usually ACE inhibitors are held 3 days prior to, warfarin is held about 5 days prior to, and then metformin and a couple of others are held just 1 day before. And then I don't have them take any medications the morning of the surgery. Then after, you also have to open a case, and the order has to be cath TAVR open. And then the documentation sheet comes to the valve clinic, and I'll put in all the pre-op orders. And my mouse, the batteries fell out. It doesn't work so well. Technical error, sorry. So this is a little backtracking, but CTAs. I know I've talked to a couple people who say, hey, we have a patient in the office, doctor's thinking about TAVR for them, they meet the qualifications, they've had an echo, they've had a myoview, what can I do to help facilitate them through the clinic? CTAs can be ordered. It must be the orders CTA TAVR chest and CTA TAVR abdomen pelvis, with and without contrast. You have those orders here also. And when you put in the order for that, and I'll give you the specific orders. The instruction portion is only about 4 lines long. The rest of it is the explanation that I always put in for the patient, because patients are getting so overloaded with all this information that you can sit in there for 20 minutes and tell them what's going to happen during their CTA, and they'll still forget. So I always put the instruction on there and the explanation of it. The CTAs are done, they're prepped in procedure scheduling. So when you place those orders for those CTAs, you then call procedure scheduling, talk to Candy or Deidre. They will call enterprise scheduling, get a date and a time for the testing, and then they'll put it on their log, and a documentation sheet is sent so that I can enter those orders. Always, before that patient leaves, check their allergies. I just had a meeting yesterday with Radiology, and this is the standard protocol that we've decided on, which matches what we already have. But if they have an allergy to an IV dye, and that allergy is hives, a rash, something along that line. If they have a topical allergy to iodine, if they're allergic to, excuse me, to shellfish, those don't count. Those are no longer applicable. It's only if it's a true allergy, as a rash or hives to the IV dye. But you'll have to send in an order to the pharmacy for these, and then the patient will take 50 milligrams of prednisone 13 hours prior to contrast. So if they have an arrival time of 12:45 for a 2 o'clock test, you calculate back to 13 hours before 2 o'clock. So 1 a.m. that patient's going to have to get up and take their first prednisone. Then it's 7 hours prior to contrast, and then they bring their last dose of prednisone and a 50 milligram Benadryl to prep recovery. If they have an allergy, you need to put in that extra order when you're ordering these, that patient can take home meds. And that will reduce the cost of the medication to the patient significantly.
So do we tell them that they need to have a driver since they're getting Benadryl, or does that make a difference?
Usually doesn't make a difference, and 99% of the time they always have someone with them.
Yeah, I figured because of the age and
Right.
frailty and stuff, yeah.
Yeah.
What happens if they have much worse intolerance to contrast?
Then we can do
Anaphylaxis.
more of an emergent, and they can also have 125 of Solumedrol IV. So this is how you get those TAVR instructions that you have printed out. Got TAVR CTA or CT and F2 through. CTA info gives you the whole explanation of that test. Also look at their renal function. If they've got renal impairment, then tell the patient that they may be required to spend a few hours after their testing getting additional hydration. And that can be up to 6 hours, depending on the renal function. When patients come in, they check in at the registration desk, just like they would for a heart cath or any other test done in prep recovery. So this goes into some questions that are frequently asked of me. Everybody's so afraid of a TAVR discharge. I have a TAVR discharge, what am I supposed to do? They're really not bad. The biggest restrictions are like with any other cardiac surgery. They have a small groin incision, typically, or occasionally they'll have a small subclavian incision. So wound care, lifting restrictions, normally 10 pounds for about the first week, just like after a heart cath. And driving. We don't like for them to drive for about a week after their TAVR, just because of that groin incision and so forth. I always go. I'm sorry. What?
What's your average length of time that they're staying?
That they're staying in the hospital. This year, average length of stay is 2 days. We've had about 11 patients out of 25 so far this year that have gone home the very next day. So they have their procedure, they're going home the next morning. They do phenomenal. The only thing that would hold that up is if they would have to have a pacemaker replacement, and that's very dependent on if they have a history of AFib, because once you restore that blood function with that new aortic valve, sometimes it irritates that heart a little bit. We had a patient that we did inpatient on Tuesday that was in AFib. We did the TAVR, and he had P waves, but no ventricular function. So he got a pacemaker
That
the
could be a
same
problem.
day. The next morning, his heart had settled down and he was back in sinus rhythm.
Is this the guy the other day?
Yes.
Oh, he was ornery. He was a
Um,
corker.
well, we kept
So was
him in
his
the.
electrical system.
Right. And he was a little bit like that because we had kept him in the hospital because he kept going in and out of AFib. His overall health state had declined so rapidly with the stenosis that we were just afraid to send him home. So it was just some juggling to get that arranged as quickly as possible for him, but he's going home today. I always mention too during the discharge the SBE precautions. They've got a bioprosthetic valve now, so they must take an antibiotic prior to any dental, even a dental cleaning. So any oral surgery, dental cleanings, anything like that. What else do we tell them? All the orders for follow-up are already in the system. As soon as that patient is done with their TAVR, I enter those orders for follow-up. And scheduling is kind enough that when those orders pop up, they automatically schedule the patient's follow-up visits. Then I also put in an order for a 30-day echo and some lab work. So that's already done for you.
Do you have the echo and the follow-up with Robertson and White the same day?
Depending on where the patient lives.
Okay,
Usually we
sure.
try to do that, but if the patient lives in Wabash,
Okay.
which is instance of this gentleman this week, we'll have the echo done the day before in Wabash, and then they just come for the visit.
So they can be done in the affiliate.
As long as they're
Hospital.
done, yes, as long as they're done with one of our echo techs.
Mhm.
So what instructions do you give them? You've also got that handout. Most of our TAVR patients now, it used to be they would go with home health care and have home health care come in and see them. And that was reducing our reimbursement rate because they were going home with home health care. So now most of them go home with telehealth and do very, very well with them. If the patient's been debilitated for a while because of another health condition, occasionally we'll send them to an ECF for rehab. And that discharge is just like any other ECF discharge that you're sending someone for rehab. It's the same order. Just include the TAVR post-discharge instruction sheet for the facility as far as the wound care and the lifting restrictions and so forth. So it's not a scary thing to do. Probably TAVR is one of the easiest things, the easiest kinds of discharge that you can do. These are your smart phrases for pre-op, for discharge, and the CTAs. Just revisiting them again, and you already have those. If the patient calls in, whether it's after their first clinic visit or after they've had their TAVR and have been discharged, if they have any questions related to the valve procedure, no matter where they are in that process, either take a note and route it to the valve pool or have them call the valve clinic number, and that number is 2267. And that rings to my desk. It also rings to Lauren David's desk upstairs. So between the two of us, we typically coordinate, and I check that line 3 times a day, and Lauren checks it as well. So if there's a question, because some of the intricacies of the whole TAVR process are unlike a standard heart cath or unlike another surgery, we don't want them to get confused. These are older patients and they're already having a hard time absorbing all the information. So we like for them to just talk with us that are familiar with their process. And obviously if they have any kind of emergency or they think it's an emergency, they can call the valve number or the after hours number. also.
After hours valve number.
No, the after hours regular number
I was like,
for
"Oh,
extenders. And then they can take a note and route it to me.
So Vicki, what's the long-term follow-up then, beyond, the?
Long-term follow-up that we have with patients is, once they're discharged after their procedure, they see Jessica Barkdale at 1 week post. They see either Kim Recht or Elena, and I can't remember her last name. Both are
Gilliam.
nurse practitioners.
Elena
Yeah.
Gilliam.
Yes, in cardiovascular surgery at 2 weeks. And then they come back to the valve clinic at 1 month with the echocardiogram, follow-up labs, and they see either Dr. White or Dr. Robertson.
But long-term after that, though, so we just see
It
them once a
depends.
year, or?
We saw, to meet registry guidelines, we have to see them then in a year.
Do an echo.
And we do an echo, and we do another KCCQ, just to assess their lifestyle. But, these patients do so great that most of the time at that month follow-up visit, we release them, we send them back to their regular cardiologist, and they do great.
And I understand that recently the patients that we can do now are more moderate rather than severe, correct?
For the Edwards valve, that has been released for moderate risk patients. We still tend to, anybody in the 50, 60 age range are still most of the time recommended for an AVR versus a TAVR, just because we all know that physicians go by hard, fast, black and white data. We don't have long-term data beyond about 10 years for the length of life for the TAVR bioprosthetic valve. So the younger the patient is, we don't know if it'll last the rest of their lifetime. We have had a couple of patients here recently that we've done the TAVR on. We had one in his 50s. We've got one coming up in his 60s that, because of other health conditions, we just felt it was best. We do have the opportunity also for someone who's had a surgical AVR. If that valve has failed, we can do a TAVR and do what's called a valve-in-valve procedure. So we can place either an Edwards or a Medtronic valve inside of their surgical valve instead of cracking their chest again. We can also do the same thing if they've had a TAVR at a younger age and that valve fails for whatever reason. We can do the same procedure, a valve-in-valve. So, lots of new things coming out there, but...
So I see we have our pre-op people here, so are most insurers starting to cover this also?
most of the time. What obstacles do you guys come across in trying to pre-cert these? Anything really?
Not as long as, because, they see the doctor, they see the cardiovascular surgeons, they have their TAVRs.
So most are covering is what you're telling us, right? Okay, that's great.
But registry just says you have to see him at the 1 year mark and then you can never see him about again.
Registry says that we have to do the echo and the KCCQ initially, again at 30 days, and then at 1 year. And then they go back to their regular cardiologist in between.
So how are they tracking, if the registry, then you just end the registry, or, how are they tracking these to see if they're lasting 10 years then?
The registry goes on.
So we do see them and we
do
still have
see
to enter
them. And I
data
believe it's
in.
again at 5 years.
Okay, that's what I'm
Our
asking.
program is 4 years old, so I haven't gotten it.
Well, I just wondered what will be the plan. I didn't know.
Yeah.
I didn't know.
It's again at 5 years, and then I think it's in 5-year increments
Yeah,
after
okay.
that. But because we were only doing high-risk patients, and those patients
And most
were
of them in their 80s.
in their late 80s
Yeah.
and 90s. One of our first TAVR patients was 96. So, their expected lifespan doesn't get us to that 5 and 10 year mark, so.
Yeah.
Except for the 50-year-old guy.
Yeah.
The 50-year-old guy
The
probably.
Yes, the 50-year, let's hope the 50-year.
Yeah, right.
Yeah. But, TAVR just is such a life-changing procedure for patients. I I always tell the story in the education class of a couple of patients that just stick in my mind that just through dramatic turnaround. We had this old gentleman, was 78, and came in a wheelchair because he couldn't, he was too short of breath, could not walk the hallway. Came in a wheelchair, his color was about the color of your paper. We saw him in valve, did all this pre-testing, had his procedure. When he came in for his 1-month visit, he was back to riding his bicycle 12 miles a day.
Wow.
12 miles a day, he was still working.
How old
And
was he?
he was 78 when he had the procedure last summer. And
It's ready to be.
that kind of a turnaround that you see so quickly, just, it always gives me goosebumps to see with these people. So there's definitely a passion for it. It's a relatively simple procedure. There's a lot of pre-testing that goes into it. There's a lot of reviewing and measuring and viewing again, but the overall outcome for the patient is just so dramatic that it's incredible.
Vicki,
Yes.
do you do the preoperative teaching then, that, before their lunch, do you do that, or they watch a video? I'm not familiar.
The pre-op teaching, once, because they go through all the testing, and usually they're given a surgery date at the second clinic visit. And when it's a fortunate clinic day and Lauren is down with Dr. Gray, we kind of tag team. But before they leave, we'll sit down and go over all their pre-op teaching and what's going to happen, what will be expected, what their length of stay probably will be, that they may have an IJ when they wake up, all of that kind of thing.
So, I'm sorry, the pamphlet that Denise just showed me that comes in that folder, you go through that with them?
That's a class.
That's the,
This
that class?
yes, the slides in this folder are the education class that I do every clinic day
Okay.
from 11 to 12.
And
you
do it.
I do it, yes. New patients, all new patients attend this. And it was a mutual decision between Dr. Gray and Dr. Robertson that, much like the hypertension clinic, this is part of participating in the clinic. And if a patient doesn't want to come in for an education class and receive that education, then they're not going to attend the clinic. So, and we've only had one patient that has refused to do the education class. So it's been very, very well received. Patients, I've got this one little guy that was just so nervous and so anxious before the class, and afterwards he was just like, well, whatever we need to do, it's great. So it just kind of goes over and quiets those fears of the unknown for them.
Now, you know, they said when TAVRs were first coming out, the life expectancy, I don't know if you talked about this, open the chest was a year or so, and the TAVRs a year or so for the life expectancy of these patients because of they're elderly, they have a lot of other issues. So what do you think so far? Has it been greater than a year?
Oh, absolutely.
Oh, yeah.
So, and these patients are still living.
Oh, absolutely.
Okay, so I think that
We
it's
have-
probably exceeded,
Oh, yes.
because
We-
when it
we have
first came out,
patients-
this was the expectancy.
We have patients that were in that first year that the program was initiated here, that we're still seeing periodically in the clinic, and
I-
doing very well.
I just attended a conference, an advisory board conference in Chicago, and they talked about structural heart disease, and they got mostly on TAVR.
Right.
They said the question we had up till now is, would they be a candidate for TAVR? They said in a couple of years, the question will be, would they be a candidate for surgery? Because TAVR will be the gold standard in the
Exactly.
future.
Exactly. And truly, it used to be the sicker the patient was, that's the only way they would qualify for TAVR, because we didn't, a brittle diabetic who had, and CHF kind of goes hand in hand with aortic stenosis, but AFib and all those other things that go on with our heart patients, the more of those things they had, that was the only way they would qualify for a TAVR, because surgeons didn't want to open them up.
And I'm sure their
And
medications change afterwards, because if they were having some
their
heart failure
medications
before,
usually,
Yeah.
yes. And that's why we follow them so closely in that first month, because we're adjusting medications, we're still assessing that wound, but we're monitoring blood pressures and heart failure symptoms and so forth.
well, you've taken the cause for their heart failure away, and so you
Exactly.
can back off and change some of their meds quite frequently.
Exactly.
And how many of these patients beforehand are on Coumadin or a NOAC?
Really not as many as you would think.
Yeah.
Probably 10%.
Oh,
Really?
Wow, that's surprising.
Yes. Which is very surprising.
Yeah.
But they,
Very cool.
yeah.
Well, anybody else has questions or,
Any other questions, comments, concerns?
well, I think you did a great job.
Great job.
And thank you.
And I hope that it just kind of takes away some of the fear of dealing with a TAVR patient, because it's more behind the scenes things that you have to do than actually with the patient.
Thanks, Vicki.
Thanks,
Thank
Vicki.
you.
Awesome.
Thank you.